it isn't a failure of dispatch to get a paramedic brain to the scene. Even if it turns out to be an over-dispatch, it's not a lack of a success story that the medic was there to determine if the patient wound up needing ALS after all. And so if you have a soft ALS dispatched followed by an ALS assessment followed by a downgrade, that is the system working as it should.
I recall anecdote after anecdote of what we've now kind of informally called bad downgrades, where there was a medic there, and during the transport, there was no medic, and there was a bad outcome for the patient. Either they decompensated on the way or shortly after transfer, or they arrived at the hospital and the hospital identified, hey, this patient's really sick, or did you do an EKG?
Ben and Roger, I love what you and all the men and women at Montgomery County have done to really empower and build a system that supports doing the right thing.
What does it really take to deliver truly patient-centered care in EMS? This is the EMS Clinical Brief, where we explore how research, clinical expertise, and patient values guide care, and how quality improvement and culture can shape what's possible. Welcome, everybody, to this episode of the EMS Clinical Brief, where we talk about the intersection between quality improvement and clinical care in pre-hospital medicine. I'm very excited to tackle this subject, which I think as a medical director and somebody who's thought about how do we optimize systems, I've had a lot of consternation about what is the best path forward. And that's really determining what is the appropriate level of care for the EMS clinician who's transporting the patient. I had been thinking a lot about this because of one-off cases. When I was sitting at home, January 2021, mid-COVID, watching NAMSP online because we didn't meet in person, and I saw this phenomenal presentation from Montgomery County EMS that showed that this wasn't just something in my head, and there were systems who'd actually really thought about how do we quantify this and tackle this as a problem. The fundamental thing here is that we do our best with dispatch. There's a certain amount of information, and the medical director of the dispatch center determines what gets dispatched to a particular call, but we know that that's incomplete information, and you're always going to have to do a patient assessment, and sometimes that's different than the dispatch information. How do we deal with this kind of given imperfection in the system to make sure that every patient is getting the care that they need? And so it's been at least 5 years since I sat there in my pajamas listening to NAMSP 2021. And after that, I immediately contacted our guests. And it's been a while since our system has sort of come around and thought about how do we move forward on it. So I'm going to introduce our guests. One of the guests is my boss in the Division of Pre-Hospital Medicine here, Monroe Livingston in upstate New York. And our guest experts are Roger Stone, who's the medical director for the County Office of Medical Oversight in Montgomery County, Maryland, and Ben Kaufman, who's the assistant chief of EMS in Montgomery County EMS. I was hoping that you all would take a minute to give your own introductions. Jeremy, do you want to start?
Happy to, and no one is the boss of Maia. Let's just be clear about that. So my name's Jeremy Cushman. I am a paramedic, emergency medicine and EMS physician who provides medical direction and oversight up in Rochester, New York, and had the great opportunity to learn from the great Roger Stone just a couple years ago when I trained at the University of Maryland, and that's actually where I got to know Roger quite well. So it's super cool to not only see the amazing stuff that he continues to do in Montgomery County, but for us to ruthlessly steal whatever good stuff we can translate up here to upstate New York.
Roger?
So the words are definitely too kind. Roger Stone. I'm a lifelong Marylander, primarily boarded in emergency medicine, proud graduate of the Christiana Care Emergency Medicine Residency, which at the time was known as the Medical Center of Delaware. So I'm very much dating myself. And after 5 years in community emergency medicine in my hometown area. And in fact, in the county where I rode the ambulance, Carroll County, Maryland, in the little town of Mount Airy, I left community medicine practice to become the first EMS fellow in Maryland when University of Maryland, UMBC, and MIMS got a combination fellowship under the old SAM sponsorships. And that is indeed where I met Jeremy, who was our fifth fellow, if I remember correctly. And we both were proud graduates of that program. I went on to stay at the University of Maryland for my emergency medicine part-time faculty career and became the associate medical director of Carroll County, which is a position I've created. And there's only ever been me in that position. Then in 2000, I was lucky enough to prevail to an RFP process that made me the medical director here. So I'm in my 26th year here at Montgomery County Fire and Rescue. That's my background.
I just love the connection between you and Jeremy. And, when we were discussing amongst our EMS docs who would join me for this, Jeremy spoke up and was like, I would love to spend some time with Roger. So, Ben, do you want to tell us a little bit about yourself?
Sure. The assistant chief of EMS in Montgomery County. I came up through the volunteer ranks as a firefighter, EMT, and then became a paramedic through University of Maryland's paramedic program. I met Dr. Stone. He was getting his one of his graduate degrees at the time and taught some of our undergrad courses, and I actually shadowed him in the ER at University of Maryland for a couple of shifts. And then started in the county in 97 and worked in the field for many years, promoting up to where I am now. So our section oversees operations, and we're fortunate to have a really robust quality management program that breaks out into QA and QI, and we also have a mobile integrated health care team. So we pride ourselves being fire-based EMS and also tackling a lot of challenges, one of which is the tiered response of ALS and BLS. So when I came up, it was 2 medic units, and that was the way we delivered ALS care, and things have changed quite a bit over the years now that we're bringing the paramedic to the scene most often on a fire engine. So it's a 4-person fire engine. One of the firefighters is a paramedic. We have a couple of chase cars left with it's just a medic in a car, but most of our transporting units are BLS.
Yeah. So in your system, transporting units are BLS, and the paramedic is essentially coming in on the fire engine for the cases that are dispatched.
We have about
ALS.
Yeah, about 20% of our units are ALS transport units, but they're one EMT driver and a paramedic. And then 30 couple transport units are EMT only. So yeah, BLS. All 34 of our engines are ALS engines. So most often it's an ambulance and a paramedic engine bringing 6 people to the scene for an ALS call.
And we now have a couple of advanced life support special service units, a paramedic rescue squad and a paramedic truck as well. So we've divorced the medic from the cot by necessity over the years to get more medics to more scenes, because our legacy medic units, as Ben has described, the 20% ALS transports, were just getting depleted too quickly with 2 medics on them and not be able to make it to calls. So at some point, more than a decade and a half ago, we had to divorce the medic from the. Plus there were advantages for 4-person staffing on the fire truck.
That's an interesting petri dish to study this problem of like, how do you get the right resource to the patient? Because I think, right, you start with one problem, which is how do I maximize ALS resources to the patients who need ALS, given a certain number of paramedics that I have? And you make that change in the system, but then sometimes that highlights or kind of has the balancing measure of when should this patient actually go with the paramedic? Like, when do you actually use the paramedic for the patient versus transport that patient BLS? And I'm gonna have Jeremy delve into our system in a little bit, which I think it's a very different setup, but I think we still have this as a universal problem. So I just think your system, it was kind of like the perfect place to initially study this and recognize this as a issue. But I think it's something that is probably in every single EMS system out there, because I don't know any EMS system that has all the resources they need, particularly ALS.
It's hard to come across a system that's all ALS transport, but that really, I mean, if every unit that's transporting has a paramedic on there, this really is not a problem, like what we're going to talk about, right? This is unique to places which most places do have mostly, BLS transport, and where it becomes an issue of like who takes the patient to the hospital at this point.
And especially in the many, many systems across the country that use a chase car model, either third service based or, for instance, in New Jersey, where, if I'm not mistaken, state law requires hospital-based chase car with few exceptions, you're going to have the whole downgrade paradigm be a cornerstone of the discussion for quality management.
And so tell me, we talked a little bit about your system, but what highlighted this issue? Like, how did you start to recognize this as a quality problem that needed a system solution?
So Roger was here at the time, but I recall anecdote after anecdote of what we've now kind of informally called bad downgrades, where there was a medic there, and during the transport, there was no medic, and there was a bad outcome for the patient. Either they decompensated on the way or shortly after transfer, or they arrived at the hospital and the hospital identified, hey, this patient's really sick, or did you do an EKG? And I think we'll probably talk a little bit about when an EKG is indicated, but there was this notion that if we did an advanced assessment on the scene, if the medic did a whole bunch of stuff, then that locked them into going to the hospital and deterred them away from doing stuff that we would have been really informative to the patient's clinical care beyond that point. So we were seeing, otherwise, why didn't you do a 12 lead? Because I didn't think the patient ultimately needed to go to the hospital. And if I did it, I needed to go. Bad idea. So we kind of encourage a full assessment, take advantage of all your tools, get all the information you can to make a good decision, and go from there.
So more specifically, data-wise, another thing that was a big trigger to how important the issue was and why we had to give it such a close scrutiny is we were starting to see with our retrospective data in the quality assurance office that somewhere close to, if not 20%, of all the quality assurance cases crossing the QA captain's desk had some sort of nexus to a downgrade. And there were trends associated with that phenomenon, which started as simple as a failure to engage enough. The so-called example would be medic gets on the scene and says something like, well, why am I here? And the EMT may not have maybe even intimidation factor, saying, well, I thought this, and the medic says, well, you're okay, aren't you? And it could be as simple as a failure to engage. We even had situations, for instance, some years back where a medic that was on an engine company that arrived on the scene of what was dispatched as a BLS call, but the patient was probably brewing something where they were more acute, and the medic saw themselves locked into, well, I'm the engine position 4, the E4, which is engine backstep behind the driver or the officer. I'm really here as a manpower piece, and helped wheel a patient that if they had engaged and dug a little deeper or had some curiosity about the call, instead of it being locked in their head, oh, I'm just going to help here. The medic was right there, but didn't actually engage. So we had a trend where the degree of engagement for different reasons may be suboptimal in those cases that turned out poorly, all the way to there was some built-in bias that may have made the medic not, provide an assessment that may not have been as thorough as it should have been. So with 20% of cases in the beginning having a nexus to downgrade, it was self-evident why this became so important, and it actually led to the scrutiny we gave it, and even the talk in 2021 during which we described this data that I just mentioned.
Yeah, and I think when I reflected, there was a few of these cases that had come across my desk, and I'd been thinking about this as a system issue. And I love that you highlight the percentage of calls, because I think most often when a case like this comes across the desk, like something is not done, people's reaction is like, oh, somebody was lazy and didn't want to do their job. And I mean, accountability is part of it, and that's probably true some of the time. But the majority of the time, if you think about it, if that's the outcome that is leading, the system is leading to results where 20% of these cases that are coming across your desk are related to downgrades, that highlights that there is fundamentally a system issue that needs to be addressed. And Ben, I love that you gave this example where people are like, oh, I felt like if I did the assessment, I have to take the patient, not if I did the assessment, it helped me determine, does this patient actually need a paramedic to transport them? And we, had very similar things in our system. And so I think when there's so much variability in a system and all these bad outcomes, coming up with an approach of like, how do we build a system that prevents these bad outcomes from happening is really key.
I think before we go any further, it's important to know that to recognize that EMD over triages, right? We're sending ALS on a far higher percentage of calls than are going to require ultimate ALS care, or patients who are, sick enough to need maybe even a transport at all. It's designed that way, right? We want to make sure we're getting the right resources there, and we're going to be sending paramedics and a high number of cases that they're not needed. Similarly, we send a ton of patients to the trauma center who ultimately don't go to the OR. We looked at data for over a couple of years of our Charlie and Delta traumas, and only 1/8 of them, so 12.5% of them end up going to the ER at all, like whether emergently or at all during their admission. So we know we still take those patients to the trauma center just in case. We still send paramedics to the scene just in case. So the downgrade, when you have a system of tiered response or the paramedics not on the transport unit, you have to have a process to say, when is it safe to leave? Because we know we're over dispatching.
Right. And this would be the corollary I should add to the caveat up front. And that is, just because once there's a QA case at the beginning, 20% may have an nexus to downgrade, doesn't at all mean that the vast majority of downgrades are suboptimal. In fact, quite the opposite. Looking at that in retrospect, the majority of these assessments, the majority of the work that the medics were doing prior to downgrading was absolutely justified and fine. The issue, and in fact, we believe somewhere around 2/3 of the over dispatching can result in a reasoned downgrade. But that remaining third, if not handled correctly, can really amount to a lot of cases if we're looking at 500 cases in the QA shop each year. So overall, it should be emphasized that we're doing a bang-up job with assessments. It's just that there were sub-trends in when things went wrong that we could wrap our hands around and our head around and start to have a response to it that is based in quality management and system improvements, which is what we may discuss a little later in the podcast.
And so before I got into the administration, the EMS administration, I was a peer member of the medical review committee, and we see these cases come up, a few times a year. And I informally would speak with the EMS administration at the time. I said, you can fix this by putting a medic on every transport unit, and we don't have all this extra work to do in the QA process. And they're like, yeah, wait till you're in my shoes. And now I am. So.
Yeah, but Ben, I think we all agree, right? The challenge that we have is because we don't have a paramedic on every truck, and we actually use EMD the way that it's designed, which is to triage our calls for service based on both urgency of response and resource need, right? Which is admittedly not how every system does it. So if some of our listeners are like, hey, I have a paramedic on every truck, and we just send a paramedic to every truck, lights and siren, we can have a separate conversation as to that's a bad idea. But in the end, this is not a problem for you. It is a problem for our very, very different systems, the system that you have down in Montgomery County and the system that I have up here in Monroe County, because we do have some very clear similarities, right? We completely agreed. We send a fair amount that dispatched ALS that may or may not need it based on time-sensitive conditions and so forth. But even by putting the paramedic on every ambulance, right? Ben, you and I go to a job, and actually I'll pick Maia because you still have your EMT, I think, right? And so Maia's my EMT partner, right? And we go to that job, and again, depending upon the agency or the system, depending on how it is dispatched, may mean that an ALS assessment is expected or it is not expected. But after I've done, my 7 ALS workups and I still have 4 hours left in my shift, there's high likelihood that if that presentation is not convincing and it was dispatched as BLS, that hey Maia, this one's yours. And so we have the same problem even if you are putting a paramedic on every ambulance.
Before we delve into some solutions, and you've hinted at it, Jeremy, but can you tell the listeners a little bit about the system within which you and I work?
Sure. So we provide medical direction and oversight for a number of counties in upstate New York, ranging from Monroe County, which is about 750,000 persons over about 700 square miles, that's managed by a single PSAP, so a single 911 center, utilizing the medical priority dispatch system for call triaging. but then gets farmed out to a tiered system that includes 34 fire departments that run the gamut from volunteer departments that do barely 100 calls a year to full career departments that do 35, 40,000 calls a year. 14 different ambulance services running the gamut from mostly nonprofit, but a few for-profit entities with very discrete service areas. And 11 law enforcement agencies, although they don't really have much of a EMS role. We also provide oversight for a very rural county, actually a couple very rural counties south of us, and so they struggle with simply response times and transport geographies because they in some cases have maybe one critical access hospital within their entire service area. So when we are trying to think about system solutions, we have to think through that we have two healthcare systems that we work closely with, and by and large, they play pretty nice in the sandbox with each other. We have at least one, if not two different PSAPs in separate counties, but we have tremendous geographic variation from hyper-urban and all of the problems that lies within, and super rural, some areas that frankly don't have much power and running water in some other areas, and so the geography associated with that. So the work that Ben and Roger have done in Montgomery, I think have really provided some context, knowing Montgomery County, that there's still some pretty out there areas of Montgomery County that recognize the fact that we're not just dealing with a singular urban area where you have a similar deployment model, because it just doesn't work that way. Our geography demands multiple different models, but more importantly, a tool that is easy enough to use and be interpretable to really allow our EMS clinicians to practice to their scope and foster good choices and good decisions when doing so.
Jeremy, could you briefly let us know what is the ALS overlay to those 34 fire department first response and the 14 ambulance services?
Yeah, so we are extremely lucky that we have pretty deep ALS. We only have one fire department that provides paramedic engine services. All of our other fire departments are BLS first response and generally only go on, if you will, some of our higher acuity type calls. And we really only have two agencies, actually about to be one agency, that is still a volunteer basic life support fire department ambulance in this area. In our rural county to the south, we have a county based EMS service that provides the majority of that, but they do work closely with a few volunteer BLS corps that staff that. So again, we do have good penetration of ALS sometimes, and so obviously when you need it, sometimes it's there, but it's honestly not always there, based on geography or time of day or holiday weekends or whatever.
And I think it's important to say is you can have an ALS service, doesn't mean you have an ALS ambulance. So, for example, one of the agencies that I'm a medical director for, Gates Ambulance, we run a lot of double BLS trucks. And sometimes we put the paramedic on the fly car, and sometimes the paramedic is on an ambulance. And actually, some of that changes day to day based on what we're able to staff. And so sometimes the issue is it gets dispatched as a BLS and you need to call for ALS resources, and are those available? And so there's so many different combinations of scenarios that involve this decision that I think are across different systems and system design. And so how do you come up with guidance and a process that works well for all of those and makes best use of the resources and gets patients the best care they need, I think is a really challenging problem. So I was hoping that Roger and Ben could share with us and the listeners what it was that you did in your system to create process where there wasn't one. Because I think there's an ad hoc process, right? There's some people who kind of like figure out and do their thing and have their practice pattern. But to decrease the variability towards good, you need to develop a structured process that is excellent, that removes kind of all that variability in practice that leads to bad outcomes. So tell us about what you did.
So I wasn't in administration when this happened, so I had to refresh myself on what the folks did. So they, we talked about the reason for it, and wanted to create a structure around it. So they started with some objective criteria with the intent of having a checklist to be used in real time by the crews who were on the scene. So the objective criteria, in order to validate that list that they'd come up with, which were vital signs criteria and the things we call high risk chief complaints, being chest pain, trouble breathing. So absence of those things, vital signs within, not super tight parameters, but like systolic between 100 and 200 and pulse not over 120, general things you'd think, well, that patient's really sick. So starting with those criteria, and then we gave those criteria to one of our busiest hospitals so we had patients who met those criteria and a big data set, and we gave that data set to our hospital. They gave us the diagnosis codes, ICD-10 codes probably at the time. They came back and said, here are the diagnosis codes. We had one of our medics who is also a nurse practitioner who went through the codes and said, after looking at each one of these diagnoses, we're really safe with the list that we've created of objective criteria. Then we put that into practice in a pilot program and assigned 3 of our stations that do a good mix of have BLS plus ALS paramedic engines, and gave the tool to those folks to employ. And we collected data on the success of the downgrade. We didn't require them to use it, but we looked at the success of the downgrade process there and said when the checklist was used, if they choose to use it, it was aligned with safe outcomes for the patient, and they met criteria for being successful for downgrade. So it's the checklist criteria, but then it's also the process itself where we say the medic says, I'm considering this patient for downgrade. They would have what's called a downgrade timeout. So when they say those words, let's have a timeout. The medic and the EMT, who's going to ultimately be responsible for transporting the patient, talk through the case. And the medic says, I'm not seeing any high risk chief complaints. The vital signs are in criteria. One of the things is a pain score less than 7. So I'm not going to treat pain on the way to the hospital. Are you seeing anything I'm not seeing? And you have this back and forth communication both ways. And sometimes the EMT would say, I'm not comfortable for, whatever the reason is. And they could talk it through and resolve, or the medic ultimately says, I hear you, I'll go with you. And that's how it's supposed to work. And, at the end, there is a checklist that's in the EPCR where they both go through and they're marked. The answers are marked, and both the EMT and the paramedic sign the checklist. So that's our way that we validate whether the work was done or not afterwards. And we continue to monitor the checklist being completed just to know whether it's done. But what we really care about is that the work is being done right, the process is being followed, and there is meaningful communication between the crews on the scene that the patient was safe for downgrade and the process was followed.
Can I just say how much I love everything you just said?
What? Yeah, one of the other things is
Maya was telling me how awesome we are. Go ahead, Maya.
Yeah, but because this is actually the quality improvement process. It wasn't like willy-nilly, I came up with things that I thought kind of made sense, and then I made something, and then I beat everybody into submission to follow it, right? Like, you came up with an idea, then you tested using data to say, is this actually likely to accomplish what we think it will accomplish? Then you developed the process, then you tested it with a small group before you implemented it more widely. I just love literally every single thing about that, because that's how quality improvement is done. So you're awesome. Now Roger can speak.
Well, it's not, hold on. We got to shout out to the people who did the work, right? Tim Burns,
Yeah. The result of our internal validation was called the ALS Down study. But one of the things that we found in the ALS Down study is that it's, although its specificity and sensitivity were not the best, the positive predictive value for the patient being safe for downgrade, if all the elements of the checklist were negative, was about 82%. And when we were able to create the checklist and we reached that degree of positive predicted value, that's where we thought it was reasonable to go live with it. What it does is it assures safety if all the elements of the checklist are negative, but it doesn't necessarily stop you from over triaging patients if all of the elements are not negative. And so for that, we introduced the medic's better judgment. Things like, for instance, if you have a person you can't say that clears the checklist because they have a high isolated blood pressure of 160 over 110 in the setting that, for instance, isn't preeclampsia or is explained by the fact that the person's forgotten to take their blood pressure medication for the last 2 days, we don't hog tie the medic into making a specific decision in every specific case. What we ask them to do is to make sure they left a paper trail and justified why the downgrade took place anyway, because even though the checklist was not cleared all the way through, there was a reason why they thought the downgrade was safe. The other part of the reward we gave them is if all the elements of the checklist are actually no and earnestly no, then that constitutes the ALS narrative that would go along with the BLS report. So in other words, they've done the checklist, the BLS writes the report, they're off the hook for any further paperwork because they've gone through this process. And this is where we could give a shout out to Tim Burns, who was really the father of our quality management program as we know it. He was the inaugural battalion chief for the quality management office under Ben. And Mario Weber, who is in JDNRP, who's now at FEMA. Mario took this project on the volunteer side of the accommodation service and was the person who brought the training for the pilot program to the one site that's all volunteer nights and weekends called the Wheaton Volunteer Rescue Squad. So I was there when he actually taught the checklist to the Wheaton medics. And then we had other people also as faculty teaching it to the career stations that were in the pilot.
So Ben and Roger, I'm curious as to the fallouts. What did you consider not quote unquote safe, right? Because both of you keep saying, well, it was safe to downgrade. It was safe to, but like, if we're looking at outcomes, like did they live or die? I think we would probably all agree there's not a lot of things that we can do to screw that up in a great context here. What did you define as a miss or as a fallout related to this?
So the actual starting point with what could become a mess is if the medic fails to engage. So we had to make sure that we were really clear on the fact that it isn't a failure of dispatch to get a paramedic brain to the scene. Even if it turns out to be an overdispatch, it's not a lack of a success story that the medic was there to determine if the patient wound up needing ALS after all. And so if you have a soft ALS dispatched followed by an ALS assessment followed by a downgrade, that is the system working as it should, right? So if there's an inappropriate or suboptimal effort to make sure that the assessment is thorough from the get-go, then that constitutes something that would ultimately lead, if you do it 50 times, you're going to have X number of bad outcomes. And so the issue of fallout is so just to make sure I understand what you mean by fallout, something that we would anticipating that the medics would be pushing back against. Is that what you mean?
No, I mean specifically, right? We're looking at is it safe for me to release this patient to my EMT partner, right? That's fundamentally the question that we're asking. And you've provided paramedic Jeremy with a tool to be able to do that. But as you determined the safety of that, what were the criteria that you used to say that the outcome was unsafe? Do you follow? Right.
So before I toss to Ben to get his position on that, one of the things that the checklist says is in bold red, any yes answer starts out favoring ALS transport. So what we call the checklist is something to jog the medic's mind. And so the process was designed to let the medic be a thinking, practicing ALS clinician with standing order credentials and privileges to make these types of decisions. And the downgrade is just another tool in their toolbox. But it would behoove folks to think about whether if there's a constellation of symptoms, either the presence of a high-risk chief complaint, which already should jog the mind, and then other things that we would hope that the medic would understand that that's not safe to fail to accompany the patient or to maybe monitor the patient or to start ALS protocols, whereas if they downgraded, they obviously would not be with the patient to continue doing certain ALS protocols. We're leaving it up to the medic to look at the totality of the evidence. Chief Burns often referred to the totality, and then having sort of a defensible, outcome to all the data that they're actually getting from that assessment. Ben, your additional thoughts on that? So we weren't trying to hogtie people with each and every decision, but at some point it becomes unsafe when you line up 100 medics and 99 of the others would not have done what you did.
I think that the crux of the issue of what Jeremy is getting at, and we're kind of skirting around it, is what needs a paramedic for transport, right? Like, how do you actually define that? Because you did things where you said, I looked up and said what these diagnoses are. But what are the things that we decide actually needs an ALS provider from the point of contact to when they get to the hospital? Like, what are those things? What are those physiologies that we are trying to detect with an initial assessment? So what kind of pathology, were you thinking of? I have the ones that are the misses in my head, right? that I'll share, but what kind of pathology were you trying to say, this patient would benefit from a paramedic?
I like to say any sign or constellation of symptoms that either indicates or heralds a potential time-dependent dysfunction of an organ system is my global definition of what constitutes the need to have an ALS person continue the transport into the hospital. And that requires a combination of knowledge and foresight and scrutiny and thoroughness, the ability to anticipate deterioration. So it is true that in the lack of a perfect world, we, despite our best efforts, we don't have a crystal ball, is what I'm saying. So the best we can do is have our mind jogged about the constellations of symptoms and signs that we find and act upon them with foresight to determine the safety. So that's a very global way of trying to answer the question. Ben, your thoughts?
No tool is perfect, and you're not going to get a perfect answer to your questions about what needs a medic. And this is like asking what the standard of care is before the call happens. It's not established. We know we know bad and we know good after the fact, right? We've developed a tool that's going to screen out patients who have the potential to decompensate or the potential to need ALS work to be done right now or on the way to the hospital. And on the way to the hospital may mean no interventions, but just ongoing monitoring and a really good workup so that the hospital gets the picture painted before the patient arrives. And a case, might be a stroke patient where there's not a ton of ALS stuff to do, but that they do need a good workup before the patient arrives at the hospital and good handoff to speed up the care that happens after arrival.
Well, I think what you're bringing up is, and I realize that there's not a simple answer to my question, because I think it is the thing that we all struggle with, right? Which is, how do I know, and what if, right? And I think sometimes the perhaps pushback that I get from my paramedic colleagues, right, is, well, I'm not going to do anything in the back of the truck on the way there. Right, Ben, to your point, on a stroke patient, I mean, what am I going to do on the blood glucometry is in the BLS scope, recognition of a stroke is in the BLS scope, right? But Roger, to your point, right, we're thinking about what additional value can I provide to that patient's trajectory through their course of care, right?
So,
I think some of it is also likely system dependent, and so. For example, my question to you is if you had a run-of-the-mill 20-something-year-old asthmatic that got albuterol, who's just having a regular kind of mild asthma attack, not requiring epi, but certainly got some albuterol, is that appropriate for releasing to the BLS clinician for that transport? Or is your expectation that there, even in that scenario, that the expectation in Montgomery County is that, hey, no, that's going ALS, even though theoretically albuterol is within the BLS scope?
We've said take one patient at a time and don't think about the patient that you're not running right now. You take care of the patient that you're with. There's always a potential for decompensation with these patients. One of the criteria encouraging ALS transport is they get a medication other than oxygen. So even aspirin or albuterol would indicate or favor ALS transport for safety reasons. And that's, but right, we're fortunate to have 50 ALS resources on the clock 24/7. So we have the benefit of saying, let's favor ALS transport in a really rural place where there might be one paramedic for, many numbers of square miles. There's a different calculus, and I can't answer that question. So.
Right. So yeah, this is where I was going to invoke a couple things. Number one, there are definite similarities between the concept of the advantages and pitfalls of the downgrade paradigm across all of our systems. The solutions, though, may need to be fine-tuned and different, because if you've seen one EMS system, you've seen one EMS system. Everything we do is associated with some degree of risk. And what this whole downgrade process for us was risk mitigation. It can't be risk elimination. So by the same token, if in a system with one medic unit for 50 square miles, like there's some Pennsylvania systems I watched on YouTube where I watched like 3/4 of the calls that the guy was self-filming, who was a chase car medic in Pennsylvania. He left the scene to go in service for the next call. It was very quick. And I was thinking maybe his medical director needs to sort of train him in that way by necessity because of the difference in the system. So we're not espousing any one solution across the systems, as opposed to saying what the similarities are in the pitfalls and advantages of a downgrade process. That being the case, I also want to invoke what I call some stoneisms. And people sort of like poke a little fun at me for mentioning that, but it does partially answer the question that you asked. The first thing that is a stoneism is you can't do for your patient if you're not with your patient. So the concept of hoping that things will get done can't occur if you don't supervise the rest of the call. That doesn't mean you should. Again, 2/3 of our dispatches may result in a downgrade reasonably, but if once you're gone, you're gone. That's the one saying. The other thing is, whenever you're doing an assessment, a way to look at this is look for ALS work to do. And that is, could I be doing something and I choose not to? Because that is a self-fulfilling prophecy when the person says, well, what am I going to do for the patient? I actually gave a lecture that was titled, What Am I going to do for a patient? And the point is that if you say that you're going to do nothing, you're using the ends to justify I'm going to do nothing. And that means that's the reason why I shouldn't have come with the patient in the first place. So an example was, I listened live to in the dispatch center one time to the arrival of a medic unit at what constituted a legacy medic unit being dispatched to what sounded like a really, really bad flu. It was just a horrible flu. And I thought for a moment as I was listening to the audible clues and I was trying to educate the civilian dispatcher, I thought I heard like gasping or sounds that were commiserate with trouble breathing, but it's probably turned out being gagging and heaving, whatever. And at the time, we could hear the medics arrive, and it was a flu. And yes, the patient, if they were just carted off BLS, curled up in a ball, could have probably done okay, just transported 15 minutes to the hospital. But then would they have been left against the wall for several minutes? How quickly before the Zofran was going to get into that person's system? And back then it was before BLS was allowed Zofran under the tongue, right? So look for ALS work would be plug that person in. My God, look at them. I could hear them over the phone. They were suffering and they didn't get the upgrade because it wasn't strictly required. But that's where one of my sayings of look for ALS work to do is something. And then a borderline ALS patient for us is an ALS patient. That may not be the case when you look at the calculus and other system, but that's one of the stoneisms. And then the other thing is when you can relieve human suffering. So that's the quadrat of some of the stoneisms that go into some of the decision making about whether we should go with the hospital. And again, different calculus if you do have 45 medics on duty at a given time in a county of 1 million versus some lesser amounts, adjusted for the population.
Is your checklist, if you will, allowed when a BLS truck requests ALS to the scene for evaluation, or is it not allowed, if you will?
Certainly. Yep. It can be used, at any point. And when there's anytime ALS is there, well, the first thing, backing up off the checklist for a minute, anytime the ALS has arrived at the scene of what was dispatched as an ALS complaint, so that would be from the PSAP or when an EMT calls for a medic to arrive at the patient's side. Before we even get to the checklist, the policy requires engagement by the ALS clinician, right? They have to put eyes on the patient, they have to assess, and then move forward from there. I think most often if EMTs have called a paramedic, they're inclined to upgrade, but not always. If they are still going down the downgrade path after that, the process is invoked the same way, right? I've assessed, I'm considering downgrade. Let's run through the checklist. So yeah, it can be used at any point. I want to double down on what Roger said about look for ALS work to do. That's what has been said at paramedic credentialing for years. It's kind of like a send off. You're go out into the world, look for ALS work to do. One of our QA officers who since retired said that regularly, like on through any even a simple remediation case would just bring that up. That's not an objective pushback, though, to somebody who says, to Jeremy's point, all I was going to do was, watch the person. Well, I didn't have any work to do on the way to the hospital. But bringing the objectivity of the checklist into play gives folks a process. And our message is that that's there for patient safety, but it's also there for your protection for times where you decide not to go, or you decide to go, right? You follow this process, you're protecting yourself and you're protecting the system. And it's not perfect. Like we said, sometimes something's going to slip through the cracks, and sometimes you're going to be over triaging. But, that has given us the system and the individuals a measure of safety by which to operate. And I think that's given a lot of relief to those of us who've, seen improvement in this area, right?
Yeah. I know you've been, and again, the fact that you have process is fundamentally the most important thing, regardless of whether you're part of the initial dispatch or you're requested later on, I think is key for all of that. And I know that you've been focused on the patient, but I'm also curious as to whether or not you've identified any additional rewards to the operations of the system in terms of resource availability or UHU or what have you, as well as, perhaps even morale and culture, because obviously you have a culture that empowers folks to have direct conversations when they're two different clinician levels. And again, you've built that process to do that, but I'm just, again, curious if you've seen any operational benefits from this as well.
When we first studied it, there was concern that this was going to take longer. So we compared ALS time on scene when the checklist was followed with times where there was no documentation that the process was followed, and the times were identical. So adding the process in did not change unit availability or ALS availability at all. There are still issues around downgrades, and some of it comes into some non-clinical operational concerns, like when we end up with the paramedic being tasked with other things, right? The paramedic may also be assigned some other role that day, as they're the unit officer or they're the unit driver. And if they were to upgrade, they're going to, miss opportunities to, finish a drill with their folks or supervise a recruit that's just come out of the academy. So we did another analysis on the frequency of the downgrade based on the unit type that responded. So everything else being equal, controlling for variables, whether we sent a chase car, a transporting medic unit, or an AFRA. And there were differences in the frequency of downgrade by percentage based on the unit type, which was, concerning. We reported on that. So, nothing's perfect, but that is worthy of talking about at the system level.
I know we've switched a little bit to talk about operational things, but I think No, I love the conversation. The one thing I don't want to skate past is some of these kind of clinical criteria. Because when I reflect, what was it about that presentation that made me hone in is one thing that was fundamentally different is that your checklist included, for example, that you had to do an EKG to downgrade the patient. And at the time, our regional policy, honestly, up until like a month ago, was that if you did an EKG, you were taking the patient. And there was a few cases where we had a patient who was dispatched ALS for some ACS type complaint and didn't get a 12 lead, not because of malintent or laziness, but because somebody was trying to preserve ALS resources, right, for the next patient. And they basically did more work to talk themselves out of doing the EKG than it would have been to do the EKG. And I reflected on this, like in the process of the emergency department, right? Like you have a tingle, shortness of breath, or pain between your nostril and your groin, and you get a 12 lead to make sure it's not a STEMI equivalent. And then we review it before you go into the waiting room. And there's lots of patients who are appropriate for that, right? They have low risk factors, they have a low risk profile, but at least they've gotten a screen to make sure that it's not a STEMI. And those cases had kind of like, they don't happen a lot. But when you have a missed occlusion myocardial infarction in the field multiple times because of kind of the system design is one of the things that I really wanted to change in the policy in the system, because I needed to make it so actually just do the 12 lead and make sure it's not a STEMI. And if the patient looks like crap, right, they're sweaty, they're diaphoretic, and they're going to have evolving changes, like they look sick for some other reason, then you should be taking them anyway. But if it dispatched a chest pain because I had a 2-minute twinge in my chest, right? At some point, I felt a little bit short of breath, and I'm 34 years old, and I have no risk factors. Like, that doesn't necessarily need consistent cardiac monitoring all the way to the hospital in the absence of other things that are concerning in terms of like vital signs or other parameters. So that's kind of like, that was one thing when I saw that presentation. The first thing I went and looked at our policy, and I said, like, I think our regional policy is creating a system that is discouraging people from doing the assessment. And what I really liked about what you're presenting is the system was about encouraging the assessment, and it's the assessment is required to make that decision. And I just like want to reflect on that, because I think a lot of systems may not have thought about how to make this a process. And then there was also this handoff process where you were having a discussion, because I think a lot of these happen as the paramedics look at the EMT and be like, you good? Right? Like, and that's the handoff, right? You haven't actually systematically reviewed all those different components. But I also wanted to take a little time to reflect on what Roger said about the relief of human suffering. I always think about this in terms of vomiting, right? Very often I am in the emergency department and I hear horrendous sounds coming from a stretcher, and the EMT is giving report while the paramedic is standing there, when I know they have Zofran in their med box, like, and I'm like, relief of human suffering is important. But on a regional level, we're doing quality improvement around pain management. And I think that is a healthy place to look at, is your system designed for the relief of human suffering and the use of resources? And even when I look at that data, well, a lot of these calls are dispatched as BLS. They might be dispatched as BLS, but we had a fair number of, old people with hip fractures, which was our last episode of this podcast, who were transported BLS with a paramedic driving the ambulance.
It's one of the things that I struggle with and have not tackled yet is EMD dispatches long bone fractures at the BLS level, when clearly these people are going to be, have a pain scale of, above 7. So they'd meet our criteria for ALS intervention for treatment. And a lot of times we do see EMTs arriving and calling for ALS for pain management. Hip fractures is a regular occurrence where we'll see that, right? We can't even begin to move this patient, onto a sheet or a reef stretcher without some relief, right? So they'll call us to the scene for those calls, but we're missing them on the front end with dispatch, right? And we haven't really fixed that, because we are still, we're not to the letter of the law following EMD, but I think we're missing some opportunities to relieve human suffering there. Yeah.
But I like having this set agreed upon criteria that says, like, these are the things where you really should be considering that there is ALS work to do, and make you think about what ALS work there is to be done. Because if you just ask people what is ALS work, there is a spectrum of opinion about what ALS work looks like. And if you ask 10 different paramedics, for some ALS work is going to be patients I would bill critical care on in the ED, and everything else is not. And then for some, ALS work is, right, like that plus the relief of suffering in all its forms, whether or not you're in vomiting or in pain. And so, like, standardizing some agreed upon thing of, like, if you see this, there's probably ALS work to be done, I think is really kind of an important agreed upon thing.
And I don't have a lot of pet peeves, but "you good" is one of them. Because I'm like, I challenge our EMTs to ask, when a paramedic asks you that, say, what do you mean by that? They might go, well, what does "you good" mean, right?
So Ben and Roger, particularly on the 12 lead acquisition thing, right? Because I think we would all agree that those are the things that we don't want to miss. Do your EMTs acquire and transmit 12 leads?
ALS. Yeah. ALS only.
So I'm curious as to any thoughts that you have on it, because and our system, we could do that. The challenge that we have is that we have no one to look at those 12 leads when they are transmitted. But it certainly enters into this discussion of, what does that look like? I realize this isn't the purpose of this discussion, but I'm just curious if you have any experiences that you would offer related to the acquisition of a 12 lead by the ALS clinician. And is that really just a single point of data in the constellation of a human being, or is it in and of itself sufficient provided everything else?
So I wanted to say that there are real live anecdotes or trends of what went into the decision to not put the medic on the hook for an automatic transport simply because you got a 12 lead. The checklist isn't calling for a 12 lead on everybody, the checklist is saying, is a 12 lead needed, and should you have gotten it? And the answer might be no, and that's the checklist. But we had, I'll give you the highlight anecdote. Medic thinks he can see the hospital over the tree line from a call, and thinking that the person was going to essentially look okay to get there. The distance to the hospital was played into the decision, and the patient had some constellation of symptom that probably some large number of medics, if you lined up 100, would have gotten a 12 lead, but worried about being on the hook and say, you know what, it's only across a tree line. What do you know? The patient is transported by BLS, gets there, and it's a rip-roaring STEMI, and the hospital on the other side of the tree line is one of the 2 out of 6 non-cath lab hospitals in the county. So the destination would have been changed by that simple, acquisition and the ability to screen at the medic level. If we transmit, they will get read, but we don't know exactly when and with what haste. The reason we have a mandate that all acquired EKGs are transmitted is so that if the BLS person arrives because it was thought to be fine and the rest of the checklist was, defensible, then at least there was someone to see that ambulance X is en route. When they pick that up and see something that the medic didn't see, it's an overread. We just don't know exactly when it'll happen. So the impetus to make sure we did not disincentivize, as Maia talked about, the acquisition as one tool in a myriad of assessment tools is because we had these kinds of horror stories that could arise if you made the medic not get it. That being said, I would not kibitz the medic that on that particular case there was only a 1% chance that the patient was having a STEMI. But if you have that 1% chance, at least if you've gotten it, your mind would have been jogged and said, "Holy crap, I didn't expect that." Or if you didn't see anything, the overread might catch it with the BLS unit en route. So that disincentive issue, did it for us. And I'm really glad that when you were in your pajamas that day, Maia, that you said, you know what, there's some truth to that in our system as well. It's one tool that you want to use if you're almost sure. But now you get the 12 lead. Okay, it's just one additional piece of evidence that the downgrade is defensible.
I think it's where you need the sensitivity in the system, right? Like I need high sensitivity from the EMS side. It's one of the reasons there's an over triage of ALS being sent to the scene, right? Like we send a lot of ALS to chest pains that do not turn out to be literally anything, but that's where we want the sensitivity in the system. And I think in the emergency department, right, that's why all these people are getting 12 leads, because there's a sensitivity thing where we're just doing a screen to identify potential badness. And so I think if somebody's a medical director, they're looking in their system and they're listening to this, and you're not saying, if you get dispatched to something that might remotely be ACS and you're not having a 12 lead done before that patient is downgrading, I think that is one clear opportunity to make a change in the system. And we'll see. We're just implementing this in our system. It took, 5 years, 5 years or something to do that. And I think there's going to be a lot of learning and questions as we roll this out. But that was kind of like the kind of epiphany moment, because I think about, have I created a system that helps people make good decisions and is sensitive for the bad things that we really need to catch pre-hospital, because it affects not just time to intervention, but also where we take the patient. And I work in a non-PCI community hospital now, and occasionally we still get these patients who get brought in by ambulance, and then there's no pre-hospital 12 lead, and it's so taken advantage of that our EMS is so good that they're always getting aspirin, they're always getting the pre-hospital 12 lead, that when it doesn't happen, we're off our game, and those patients have significant delays. So we're kind of at the top of the hour. And so there's a bunch of resources I'm going to leave. I'm going to leave our regional clinical policy, and I'm going to get a bunch of good, juicy stuff from Roger, because you have lots of posters and the checklist, which was really the basis of where we started. It made our life really easy because somebody had done all that work already. But I wanted to go around to kind of each of you and say, what is your take home? If you had kind of one piece of advice to somebody who's either an EMT or a paramedic or a medical director around this issue, what would it be?
I think at the system level, if you add a process in to give your folks some safety, right? Give them a construct, some guardrails to work between, and give them confidence in their decisions beyond the somewhat vague look for ALS work to do, because you also don't want people to go to the hospital every time. You want them confident in their decisions, and give the EMTs an opportunity to push back on the "you good," right? And it really puts medics who are maybe erring on the side of not going to confront the reality of a decision. Like, I'm getting ready to send this person with, tearing abdominal pain and abnormal vital signs in an ambulance. Maybe I should wait a minute and rethink my decision, right? So at the system level, you give people an opportunity to make good decisions by adding a process in.
And I would zoom out and say that one of the take homes is all of us wake up in the morning to go to work, and one of the first things we want to do is, above all, do no harm, right? And when we happen to be ALS clinicians, we're equipped with some training, not only in what we do, but how we think. That's based on additional anatomy and physiology training, and an ability to synthesize what's going on with homeostasis versus abnormal presentations. And we're trained to do it a little bit better than the EMTs. The EMTs, excellent EMTs all across the country, every single day, have a sixth sense of what's sick and not sick. So above all, when we reach the scene, we have to think about, why we're there. And sometimes, and we didn't mention this before, and it's probably a take-home message, get a good dispatch history. Because if there's a mismatch between what you thought you were going to be, fine when you got there and when you actually get there, then investigate that with the patient. And then all this is part of the culture of safety. When you get into an airplane, which is one of the safest places to be in American transportation, part of the reason why it's one of the safest places to be is because there are processes and these guardrails in place, including a pre-flight checklist by the pilots. And the pilots then take off because they make sure they do that each and every time without fail, that your flight has a 99.99999% of arriving safely. We can't quite get that safe with paramedicine and downgrades, but we can strive for it. And all our process is borrowing from the adage of, you gather data, you engage, you gather data once you're there, you look at the constellation and the totality of evidence you have in front of you, and then you make a decision within the guardrails that Ben talked about. And you're then destined, with all those other stoneisms I talked about, you're then destined to probably do a good job the overwhelming amount of time that you're a medic, and it adds to your ability to make sure that you do the best you can for your patients. So that's the way I'd sum it up.
Jeremy, the last word.
Ben and Roger, I love what you and all the men and women at Montgomery County have done to really empower and build a system that supports doing the right thing and allowing our EMS clinicians to be just that, clinicians, and not the technician that I was 35 years ago who just showed up and dragged them to the hospital, whether they wanted to go or not. And so I think, the tool that you have built, we have ruthlessly plagiarized in our system to also do just that. So that our EMS clinicians can act as such. And with that, there's some responsibility. There's some responsibility to our patients and to each other, to our EMT partners, to our other paramedics, of ultimately doing right by the patient. And so to see and understand the process by which you got here to create that system and that construct. And it's certainly helping us up here in Rochester. And I'm sure it's helped a lot of systems across the country, because we don't all have the unlimited resources and the ALS trucks everywhere and everybody getting everything every day. So kudos to y'all for doing that and having such a great team that supports that empowerment.
Thank you so much for your time, your wisdom, sharing all your resources, and thank you to listeners for tuning in. Until next time.